Welcome, Kai and Laura, and welcome everybody. And I would like to say good afternoon to people from Africa and good morning from those from USA. So I think as I know some people are getting challenges joining, but we can start the meeting because it is quite so many minutes past. Again, I would like to welcome you all to today's session and to this knowledge sharing platform of the Africa Cancer Research and Control ECHO. My name is Annette Nakaganda, a cancer epidemiologist based at the Uganda Cancer Institute, and I'm going to be leading today's session. A special welcome to those attending for their first time. This is the Africa Cancer Research and Control ECHO. And as you may have been told, this ECHO aims at expanding and sustaining best practices for cancer control, planning and implementation, as well as increasing the utilization of evidence in directing the cancer control effort in the region. So today's session is about cancer research and COVID-19, particularly the impact of COVID pandemic on cancer prevention activities and participation in research. Specifically, we are going to explore the impact of COVID-19 on grant-funded cancer prevention programs, and also highlight current research and share experiences about generating and using evidence to inform cancer care in the COVID-19 era. So I welcome everyone once again to this important discussion. And before I invite the first speaker, I wish to remind you that we shall have two short presentations today, followed by a detailed discussion as stipulated in the agenda you have. I would also like to remind you to mute your microphone, please, if you are not speaking. If your bandwidth permits, please turn on your video because we like so much to see your faces as we go along with this discussion. In addition, please use a chat window at any time to introduce yourself, ask questions, or make comments. I also want to remind you that sessions are going to be recorded and will be sent out to you after this session. So at this point, I would like to invite Dr. Laura Muzingwan from Namibia to share her experience about COVID-19 era and the cervical cancer prevention and screening program she's leading. Laura is a cervical cancer prevention lead physician working for the International Training Center for Health, commonly known as ITEC, which is affiliated to the University of Washington, Seattle. Currently, her work is focused on supporting the Namibia Ministry of Health and Social Services to design and implement a cervical cancer prevention program. She also has several years of experience in training health workers to implement cervical cancer screening for about 4 years. And she's currently part of the team working to analyze if lowering the age of cervical cancer screening is beneficial. So Dr. Laura, you are most welcome once again, and please have the floor.
Thank you very much, Annette, and welcome everyone. We'll just start sharing my screen. All right. Can you all see my screen? Thumbs up if you can.
Yes, Laura, maybe you can make it a slideshow. Yeah.
Okay.
Excellent. Sure. Perfect. Thank you.
All right. Great. Thank you. So I'll start with a bit of background in terms of how COVID has been impacting Namibia, and also go through the cervical cancer screening in Namibia and how COVID has actually impacted the cervical cancer screening and what we are doing about it. So the first COVID-19 case was detected in Namibia on the 14th of March, 2020. And then this had quite a ripple effect, as most of you have experienced as well. A state of emergency was declared with social distancing measures instituted, as well as having schools closed. We had a partial lockdown of 2 main regions within the country, Khomas and Erongo, for a period of about 3 weeks, just to monitor the situation. And as the cases continued to increase, the lockdown was extended to cover the entire country on the 17th of April, and is expected to end on the 4th of May. The current statistics in terms of COVID-19 a total of 16 cases were identified, 8 have recovered, and 8 are still active. And thankfully, we haven't had any deaths so far. So in terms of cervical cancer prevention in Namibia, the primary prevention aspect in terms of HPV vaccine is mainly limited to the private institutions. It's not yet available in the public sector. But although it's available in the private institution, they've been also experiencing challenges in terms of accessing it, as there's been a global sort of shortage of the HPV vaccine. Then secondary prevention, screening was mainly pap smear based until October 2018 when VI screening was introduced. And HPV testing is also done in some private institutions, but this is still at a very low scale. Treatment of precancer lesions is being done in the public sector through cryotherapy, and we introduced thermocoagulation last year in September. And we are also doing that for the more advanced precancerous lesions. So in terms of service delivery models for secondary prevention, we have the static as well as outreach or mobile sites. The static being mainly facility-based at primary healthcare centers, and it's also integrated into HIV care and treatment clinics. Outreach services are in the form of mass screening campaigns, usually in the hard-to-reach areas. And this is targeted at women who do not frequent the healthcare facilities and trying to bring services closer to them. So what has been the impact of COVID-19 in terms of cervical cancer screening activities? The social distancing measures and travel restrictions meant that we could not send the more skilled staff to the different regions, who tend to be mainly in the capital city, and they now cannot travel to the different smaller regions to offer technical support. And we also cannot lump together staff to conduct mass campaigns and outreaches, as these are all efforts to try and curb the spread of coronavirus. Our trainings for VIA, since it's something relatively new and this is something we have been actively doing, have also been suspended because this also involved having participants congregate within one area. And we also experienced staff being moved from the SICA program to support mainly COVID-related activities, as these take a bit of a higher priority compared to everyone else. In terms of screening, okay, it's fine. In terms of screening, it's limited to only one. Sorry, can you just go? Sorry, excuse me. So screening is limited to only those coming to facilities for other services, such as ART patients coming for pill pickup. And this is something that we have also started to note, that women are actually shunning healthcare facilities as they're afraid that they will contract COVID-19 at the facilities. Some of them that we have talked to actually think that because the healthcare workers are not always having PPEs to cover themselves, they might actually serve as the vehicle to transmit infection to the women. So they would rather not come for screening and come at a later date. So what to do now with such a scenario? Some measures have been implemented to try and make the healthcare centers safer for our women. We have implemented trial systems to screen for and isolate suspect COVID-19 cases before entering healthcare facilities. PPEs, though inadequate, are also being availed to healthcare workers who are engaged in this trial system for screening as well. And we've also started planning for catch-up activities to make up for the lost time. This is in the form of getting contact information for women and also getting consumables in place just to kickstart campaigns once the restrictions have been lifted. Although we don't know really when this will be, but just getting prepared. We are also in the process of availing information to women about why they should get screened for cervical cancer. Then the women who were already identified as having precancerous lesions are being actively traced to go for treatment at less facilities. Some still have reservations, but once we give the explanation that, you know what, you're actually on the way of developing cancer, and if we don't remove this, you might actually have cancer in the end, instead of just being afraid that if I visit the facility, I may or may not get coronavirus infection. So we find that after some explanations, especially for the women with precancerous lesions, they do tend to come up for their treatments. So just for discussion, I'm just going to pose these questions later on so that we think about them. Self-sampling screening tests like high risk for high risk HPV, they reduce client exposure to healthcare facilities. But in low resource settings, such as where I'm working, these tests are quite unaffordable. So how and where can we lobby for these tests to be availed at minimal cost? And this is thinking, should we face another pandemic? These are some of the things that we could do to actually mitigate the effects. Then I also want to know how other countries are managing in terms of HPV vaccines due to the multiple doses that are required. Are they meeting, are the young women coming for their vaccines at the time that they are supposed to, considering the restrictions that may be in place in terms of COVID-19? And as we also venture into the more advanced technological aspect, how can telemedicine be used to improve cervical cancer prevention activities in the face of a pandemic as well? Thank you. And that concludes my my presentation. I'll stop share.
Thank you. Yeah. Thank you so much, Laura. This is really a very exciting, you know, a powerful presentation and thought-provoking. So, as I said, dear colleagues, once again, as a point of reminder, please take note of your questions or comments, or you can put them on the chat window, because we are going to have protected time at the end for a detailed discussion of Laura's presentation, especially the dilemmas we are facing in this time. So if you feel you're going to forget, just post the questions on the window and then we shall take care of them at the end. At this moment, I'm really greatly honored to invite and introduce Dr. Sao Kai from Mount Sinai Hospital, New York. Kai is the medical director of the Ruterberg Treatment Center at the Tissue Cancer Center, Mount Sinai Hospital. He leads a multidisciplinary treatment center in delivering the highest quality patient-centered care to those affected by cancer and blood disorders. In the midst of COVID-19 pandemic, he has been an active member of the Multidisciplinary Task Force for Strategic Development and Care Transformation in mitigating the risk for cancer patients at the Tissue Cancer Institute. He's an associate professor of medicine, hematology, and medical oncology at the Icahn School of Medicine at Mount Sinai, and is on staff at Tissue Cancer Center of the Mount Sinai Hospital. He's actively involved in research of the development of novel therapies in the treatment of genitourinary cancers. His main focus is in defining clinical and molecular phenotype of prostate, kidney, and blood cancers, as well as treatments for the disease.
Thank you, Annette.
Yeah, please, I'm requesting you to mute yourselves if you are not speaking. Dr. Sao, please is going to take through us the next session, and please, over to you.
Great. Thank you, Annette, for that wonderful introduction. I'm really excited and honored to join this forum. I think it's a challenging time globally for all of us, and I'm excited to share some of our experience here at Mount Sinai. The topic for my few slides is really to talk about risk mitigation in patients with cancer during the COVID-19 pandemic. So just a little bit about Mount Sinai Hospital. Mount Sinai Hospital was founded in 1852, so we have many, many years of history. It's currently a tertiary hospital with a little over 1,100 beds. And you can see here on the left side, this is the picture of Mount Sinai Hospital. We're located in Manhattan on the Upper East Side, between 98th Street, which is here, and then 103rd Street, which is here. So this is Mount Sinai buildings. You can see this is the beautiful Central Park, which we haven't had enough social distancing in, but we hope that we'll slowly get there. It's hard with the weather getting better and better. In fact, some interesting thoughts. So this is the Cancer Center. This is the Leon Hess building, which we opened about 7 years ago. And in this Cancer Center, which is an outpatient center, we have all our facilities within this site, where our clinical practices are on the middle floors, our researchers on the top floors. And then in the bottom area, we have a radiation oncology and radiation oncology. You can see here on the right side, this is the building that I'm currently located in our outpatient cancer center. This is the Mount Sinai School of Medicine. Our School of Medicine is located here. And this is mainly our two hospital buildings here on these two sides. So currently we're really a healthcare system of 8 hospitals with over 3,300 beds and over 42,000 employees, with close to 7,000 physicians. Across the different hospitals are located in different boroughs, and also Long Island, which is local to the 5 boroughs. Our cancer program is really through the Tisch Cancer Institute, which is actually relatively new. We started the Tisch Cancer Institute in 2008, a year before I joined Mount Sinai. And we received our NCI designation in 2014. And the Runberg Treatment Center is our multidisciplinary cancer center, where we provide cancer care to approximately 10,000 patients a year. We have about 86 doctors working here in the multidisciplinary teams to provide cancer care. So let's talk a little bit about New York City. And as you guys all know, New York City has really been the epicenter globally of the COVID-19 pandemic. If you could see that our total population in New York City is 8.7 million. To date, this is data from yesterday, we have 157,000 confirmed diagnosis of COVID-19. But there's recent data where the New York State governor randomly sampled COVID-19 antibodies on the street. So they randomly sampled thousands of patients on the street and drew antibody tests. And so that close to a quarter of residents in New York City actually had positive antibodies. Taking away the false positives, we're thinking between 20 and 25% of New York City residents potentially could have already been infected with the COVID-19 infection. So when you take that number and extrapolate to the 8.7 million, we're talking about a couple of million people potentially already affected, which has really led to some of the numbers that we're seeing. And, just as a reminder, we really only had our first reported cases in New York State in the first week of March. And you can see that this is in terms of case counts and hospitalizations, that our apex, the so-called apex, was in the beginning of April. And that has really slowly come down. And you can see here, similarly with the hospitalizations, the apex was really in April. And thankfully, we've seen a flattening and then a decrease right now in terms of the number of hospitalized COVID-19 patients. For Mount Sinai Hospital, we're approximately at about 50% of what we were 3 to 4 weeks ago in terms of COVID-19 hospitalized patients. So this is New York City mortality. And just to point out a couple of things here, we know that COVID-19 severity and mortality is heavily reliant upon a couple of things. Number one is underlying conditions. You can see that regardless of age group, underlying conditions, patients are at much higher risk than those without underlying conditions. Age, obviously, this is the rate of COVID-19 mortality per 100,000 people. You can see the older you are, the more susceptible you are to mortality in an age-dependent manner. And certainly, I think we've appreciated this for a while, that there is a higher risk of mortality within the male population. There's a number of reasons that's hypothesized. And very interesting, and this is seen in other data sets also. It is very clear that in the United States, we see that whether in terms of overall incidence, non-hospitalized, non-fatal hospitalized, or fatality, that there is an increased rate among the Black and African Americans and the Hispanic and Latinos, comparatively to those who are Caucasian and Asian. And we have to do more research, and we have to investigate further to understand why, but a number of factors which we think can come into play, cultural factors, socioeconomic factors, and potentially other factors. This is really an area of intensive investigation at this time. So what do we know about cancer and COVID-19? Well, we know cancer patients tend to have an advanced age. Age is a risk factor for many, many cancers. We know that our cancer patients tend to have comorbidities that are associated with worse outcomes of COVID-19, hypertension, cardiac disease, diabetes, among others. And we know that cancer therapy can cause immune suppression and immune dysregulation, which really puts this patient population at risk. Limited data exists to establish this risk, but we really, in the setting of having this pandemic hitting us and lacking data, we have to focus on develop the best practice guidelines to mitigate risk for this patient population. So the best data, actually, this was published just 2 days ago. But prior to this, the same group had published a case study of 28 cancer patients, and very preliminary report that these patients had worse outcomes comparatively than the rest of the population. But this is from the same group, just within much larger cohorts. And in this cancer discovery paper, they looked at 104 cancer patients across 14 hospitals in Wuhan, China, and they age matched 536. Remember, these are hospitalized COVID-19 patients. And the other cohort is the 536 age-matched non-cancer patients. And I know we have a lot of epidemiologists, so these are the statistical analysis they perform on the data set. So they had some very interesting findings. So they saw that patients with cancer were more likely to have in-hospital infection. They were more likely to be smokers. They were more likely to use antibiotics during their hospitalization. They're more likely to get intubated, to be on CRRT, as well as ECMO. In regards to their multivariable logistic regression analysis, when they adjusted for comorbidities, they saw a trend for high mortality with the odds ratio of 2.17 in patients with cancer versus non-cancer. They noted a higher odds ratio of ICU admission, severity of disease, as well as mechanical ventilation as well. So specifically, they also have looked at specific cancer types. And this is a small cohort. You can see these total numbers here, 22, 9, 11, 13. But interestingly, those with lung cancer and blood cancer were at the highest risk of having mortality with the COVID-19 hospitalization, 18% for lung cancer, 33% for blood cancer. And this is thought-provoking. And certainly we know that not all cancers are the same and their treatments are very different. So as we have the evolving data, we need to focus on how do we protect specific populations of patients. So what about cancer therapy and COVID-19 outcomes? So a small subset of patients of the 100 and so cohort cancer patients had therapy within 40 days of their COVID-19 hospitalization. What they saw was, and you can see here this graph here, the blue one shows no cancer, green is radiotherapy, red is chemotherapy, purple is surgery, and brown is immunotherapy. And the asterisk shows that it's statistically significant. You can see that, interestingly, remember these are very small data sets, so hypothesis generating, but they saw no difference if you had recent radiation in terms of outcomes, cancer versus non-cancer. But certainly, when you're talking about surgery, chemotherapy, and immunotherapy, again, small numbers, but these patients were at high risk comparatively of developing complications, and in the case of immunotherapy, higher risk of mortality compared to those without cancer. So the question with this data is really, how do we mitigate COVID-19 risk for patients with cancer in a time where the pandemic has really rapidly evolved over the last 2 months, and now we'll get to breathe a little bit as we pass the apex. Throughout this time, what we did at Mount Sinai is in the first week of March with the first reported cases, we really prioritize the 5 objectives that I listed here, which is to minimize non-urgent cancer care, to expand telehealth care, to implement COVID-19 screening, to develop care pathways, and really to establish best practice for testing and treatment. So I'll go over in detail some of these objectives. So in terms of minimizing non-urgent cancer care, what we're trying to do is we're trying to decrease transmission risk for patients. So we prioritize patients getting their care locally. At Mount Sinai Hospital, some of our patients are traveling hours from the tri-state area, Long Island, and what we want to do is provide the care during the pandemic, so it decreases their risk by having to come outside of their house, getting scans, getting the care that potentially we can defer and mitigate their COVID-19 risk. So what we did was we asked all our doctors and nurses to review with each patient their risk and benefit of their current treatment, of their current follow-up. We asked them whether to decide whether the patients can be cared from home or locally versus coming on site. We talked about if the diagnostics is urgent, then we'll proceed, but if not, to be deferred. Also, choice of cancer therapy is important. There are some therapies that are oral, that are less myelosuppressive, and which can be opted comparatively to other types of therapy. And also there is the talk about giving treatment holiday, for example. So we also, in setting of this, suspended our clinical trial accruals. We know that patients on clinical trials often is intensive in terms of their care and their diagnostics. And while we stop clinical trial accrual for new patients, we continue treatment of those patients who are existing clinical trials. But we also were able to work with the sponsors in our IRB to care for these patients, a lot of these patients remotely. So we'll send the medications to them if possible. We did telemedicine follow-up care for these patients. And really our goal is to minimize the transmission risk for these patients while they commute and receive care. And you can see that these are our volume prior to COVID, where we often saw 500 and 600 patients a day during COVID time, prior to COVID times. And currently we've cut down that by over 80% to 100 a day. Previously, cancer care, our cancer clinicians have not traditionally used telemedicine because, as you can imagine, cancer care is difficult a lot of times to provide with telemedicine care. But our faculty, our doctors have done an excellent job, and now we're approaching 100 a day in terms of doing telemedicine visits. And in terms of intravenous infusion for cancer care, we're on average about 200 a day that we're doing in our outpatient center. We're currently at about 110, 120, although these numbers I've just saw this morning is going up. What about telehealth care? This has been really, really difficult to do, but these are our numbers of visits, total number of visits with the telehealth visits in the dark blue bar, and the non-face-to-face, which is really a telephone care coordination care visit type. And you can see that more than half of our total visits now are with remote telehealth. But to make this happen, we really need to standardize the workflow. We need to provide both the hardware and the IT equipment and the software that's associated. It's about a lot of efforts and on staff education of how to do this, who is appropriate. Patient communication is a big part of this. And really to expand its use, we had to minimize restrictions. One of the biggest obstacles is billing in the United States in regards to who can do telehealth or not. But we work with our administrators to really work on the back end so that our clinicians can provide the care they can remotely, and then they'll worry about whether they can bill enough afterwards. We also, as a third objective, really focus on implementing COVID-19 screening. We know that it's important to minimize transmission risk as well as provide the best care. So what we did was we developed an automatic robot call 48 hours before patient appointments to remind them that if they have COVID-like symptoms, to call their clinical teams. We have a real person 24 hours ahead of their appointment, an oncology trained nurse to call the patients for screening again. And at the date of appointment at the entrance, we ask all patients and staff to mask when they come in. We provide a temperature check, and we also do a screening questionnaire. If patients are suspected to be a person under investigation, they're now escorted to pathways where they'll be in an isolated room and receive care appropriately. And what's really, really important is, especially when we started on this journey and with this pandemic, early disease recognition and appropriate care is really, really important. So we're working with the hospital, and our Mount Sinai Hospital has developed best practice guidelines in terms of treating COVID-19. Testing has been a large barrier for all of us, and I think we're now at a time where we're able to offer all patients who need a test, but that wasn't always the case. And it wasn't always the case until just maybe about 2 to 3 weeks ago. Education is really important. Educating patients about social distance and masking, hand hygiene for those who are appropriate. Isolation, quarantine is absolutely critical. We also develop a number of care pathways, and it's really important for us to develop these distinct care and testing pathways so that we don't intermix the patients and increase those transmission risks. So we develop pathways for testing and care for those who are COVID positive symptomatic versus COVID positive asymptomatic. And that's really important because we know that a lot of patients can be positive, but they can be asymptomatic, but they're shedding the virus and still can pose a transmission risk to others. We have a pathway for personnel under investigation and for those patients who are COVID negative. To really enable us to do this, we had to create these separate units. We created a 24/7 outpatient care unit for COVID positive patients for their care. We also created a 14-bed inpatient unit for those patients who are COVID negative that needs inpatient care, so they don't have to go to the main hospital and receive their care, where we're primarily taking care of actively symptomatic COVID positive patients. And really what's really important in all of this is we really constantly had to educate all of our staff at all levels of care so that they could direct the patients to the distinct pathways of care. One thing that's developed more recently is how do we establish a best practice for testing and treatment. And currently we are recommending all patients who are asymptomatic that needs an urgent surgery to have a COVID-19 PCR testing within 24 hours. And they can only proceed with surgery if they were negative, and in cases if they're positive, if it's medically urgent. We don't have such precautions for radiotherapy, but for chemotherapy and immunotherapy, we're recommending that prior to start of therapy, 24 to 36 hours prior, the COVID-19 testing is mandatory. Testing every cycle of treatment is recommended. And if patient turns out to be positive, we recommend withholding treatment unless clinically urgent. So in summary, we know that patients with cancer are high risk to develop complications, mortality from the infection. To mitigate such risks, we took a programmatic approach, screening, telehealth care, testing, care pathways, and really standardized treatment decisions. I think what's really critical is we have to use evolving evidence to develop practice guidelines, because our guidelines are constantly changing based on the available evidence. And currently, we have a number of efforts, whether it's therapeutic clinical trials. We're part of the antibody testing studies that initially, we have one of the 7 FDA-approved tests here at Mount Sinai for antibody testing. We have an anticoagulation standard care practice program here where we anticoagulate all patients with severe COVID infections, because we've seen that there's a large number of thromboembolic events in this patient population. We're a part of a number of therapeutic trials, the convalescent plasma program, remdesivir clinical trials, the azithromycin, hydroxychloroquine, among other therapeutic trials. So it's really important for us to kind of continue to follow that in terms of developing our best practice pathways. And really importantly is really to understand our paid cancer population. So we're currently collecting data, looking at incidence, looking at the possible complications of treatment of those who are positive asymptomatics. So a number of things I think in the coming months will help us to develop better and better evidence-driven pathways to best care for our patients. I think that's it from me.
Yes, thank you so much, Kai. This is really great knowledge, and we have a lot to learn. And thank you for sharing about the steps being taken, the research, and using the research to inform your care. So, colleagues, I would like to welcome you now to ask questions, pose your perspectives, ideas, and your thoughts on how things can be done better. You can just speak out or put your comments and ideas on the chat. And now, let me cross-check if there is anything on the chat. Yeah, we can start with discussing the questions from Rora. Let me see if I need to.
Looks like Benda has raised her hand. Benda,
Sorry?
Benda has raised her hand to ask a
Yes,
question.
Benda, please go on.
Actually, yes, thank you so much for the two presenters. That was quite insightful. And I was actually going to speak into what Laura had asked, so it's just as well you've projected them on. So I know quite a number of the countries that were on the Clinton Health screening program, and because that was still ongoing, like in Kenya, it's ongoing, and they have been training healthcare workers to provide service for screening. One of the questions that we raised today morning in our Stop Cervical Cancer initiative was, is there an opportunity to start thinking about shifting from in-facility provision of screening to out-of-facility self-collection and utilizing the mechanism for the community health volunteers? Maybe that's a question that we all ought to be asking ourselves, and so that we can lobby collectively and also advocate collectively for the change to self-collection as opposed to in-facility. The second one is, one of the barriers that you mentioned was the fear of infection with COVID-19, and therefore maybe what we ought to be thinking about is provision of PPEs for the healthcare workers, so that, and especially in our region where we find challenges with PPEs, if there was a way to support that so that it can support the screening services ongoing at the lowest facilities, maybe that would help. On the HPV vaccine, and how are we ensuring that our girls continue to receive the vaccine? Quite honestly, that's a bit of a dilemma. In Kenya, this month we ought to be administering the second dose because we started in October 18th, 2019. But right now, as you mentioned, people are afraid to go to the facility for fear of infection. So one of the things that we've done as Women for Cancer and the cancer community, including the Kenya Network of Cancer Organizations, is this week we are commemorating the African Vaccines Week. And we did a toolkit that has been used by various partners in communicating vaccines work. And we have seen quite a bit of comments, quite a bit of engagement on social media. And one of the thing that I would ask of all of us is to continue conversations around vaccines so that people know that this is one of the ways to prevent diseases. And even after COVID-19 is dealt with, and after it is managed and controlled, we will still need to go back to our essential services provision. That is what I had to offer. Thank you.
Yeah, thank you so much, Benda. And those are really very good points to consider on the way forward. Yeah, I know, I think for now we need to really plan, because the discussion now is to plan for what will happen after the COVID era. But before we even think of after, we need to think of what to do with this pandemic, because it is something that will not go quickly. Because today I was just reading that in Ghana, after lifting the lockdown, the ban, again, they registered about 200, up to 300 cases of COVID in a day. So it's almost doubled. So they may have to go back to lockdown again. So I think before we even think of what to do after the pandemic, we really need to see how to sustain, how to plan, and go ahead with these services. So I don't know whether people have more questions. I would like to ask about Dr. Sao. A question. Thank you, Kai, for the great presentation. I don't know how you handle patients who have palliative care needs for cancer, because it may not be very common there, but in Africa, we still diagnose most of the cases very advanced, almost 80% come with advanced disease, and we emphasize a lot of palliative care. So would like to hear your experience now in the COVID-19 era. How do you handle the palliative care needs and end-of-life care for cancer patients?
Yeah, and that's really an interesting question. So I'll answer this in terms of inpatient and outpatients. Obviously, we've seen a lot of deaths with COVID-19, and the frustration is that because of the nature of the disease, we've had a no visitor policy for patients in the hospital. What that means is during the course of their treatments, their families are not allowed to visit them. And certainly that's been a challenge, particularly a lot of patients were dying. Now, we do allow in special circumstances for patients' families to come in, including at the end of life. But certainly that journey has been extraordinarily difficult for many of the patients and families. We actually have, at Mount Sinai, have one of the largest geriatric/PAL care teams in the country. So we're very fortunate that we're well-staffed in that regard. So from the inpatient side, we were able to offer a lot of telemedicine in terms of supports. We provided iPads and robot video conference machines so that the patient's family can be involved in a part of the visits, particularly with palliative care and kind of end-of-life care, goals of care meetings as such. So despite the frustrations on an inpatient standpoint, I think, that our PAL care doctors are able to use technology to reach, to better reach some families, but it doesn't take away the fact that, unfortunately, some of the patients pass away without kind of having their family next to them. Remember, a lot of these COVID-19 patients are intubated and really never wake up, unfortunately. So from the outpatient cancer program side, during this effort, we've decreased a lot of our outpatient volume. As you saw, we decreased the in-person outpatient volume by 80%. So with that, we work with our PAL care lead for cancer and offer telemedicine for those patients who are palliative medicine for those patients who are having specific issues, pain control, goals of care. So really telemedicine has been key for us. Remember, the COVID-19 really affected our staff too. So we had a number of doctors and nurses and other healthcare workers that got sick during this process. So, and we're also a part of our workforce were deployed to the hospital because our beds had to double within a week or two as mandated by the state and also dictated by the volume. So I think telemedicine has really helped from a programmatic need to address the PAL care needs for our patients.
Yeah, thank you so much. I think you tackled also the question that was on the chat where someone wanted to know about the specificities of the telemedicine. What do you actually provide in telemedicine?
Sure.
Yeah, I've projected it if you can see. So thank you so much.
So Vidya, I was the telemedicine lead for our cancer program, which had been very painful. I have to say that number one, there are 4 parties that we had to overcome. There is the insurance side, right? So very early on, the U.S. government announced that for CMS, so for the federally insured insurances, that they will waive limitations. So previous limitations were the type of visits, whether it's a new visit or established patient, location of the provider, where the patient is. You have both had to be located in the state of your license. So those are restrictions that were lifted for federally insured programs. But there are patients with private insurances without these restrictions being lifted. And then there's the patient side. There are patients who have caretakers. There are patients with limited, IT capabilities, whether it's whether they have a smartphone or iPad, whether they can maneuver around the software, the app-based programs that we need to offer for telehealth care. And then there's the physician side, to adapt, who to choose, who not to choose, what if I miss something? There's the legal side of it also, right? Like, what if I miss something on the exam? I can't examine the patients. I don't have lab work available. For cancer patients, I need to coordinate care. I need to do a scan and do lab work. How do I know if, somebody's having diarrhea from cancer treatment, that they're now not hypovolemic and hyponatremic? So really educating the staff about what's appropriate, what's not appropriate. And also the administrative side. You know, the reality is for the U.S. healthcare system, all hospitals are losing a lot of revenue because of the inability to perform elective procedures. And, you know, how can we allow the doctors to do telemedicine when the reimbursements are much lower? So those are kind of the barriers we've had, and really we focus on all 4 barriers and address, you know, using the barriers and then really map out what the challenges were and address each of them. I think right now we're able to do as much as possible. So we have staff that calls patients to address, you know, to educate patients about what their capability needs to be in terms of whether they need somebody to be with them during the visit or not. Make sure they download the right app and knows how to navigate through the app. We've worked with our administrators to really, as I said, work on the back end, allow the doctors to do telemedicine visit for everybody. And you guys bill when it's appropriate, but maybe not bill when it's not appropriate. So we've done those measures to really lift the restrictions. But you know, the reality is my frustration, and I'm somebody, in fact, I have 8 telemedicine calls scheduled later today. And a lot of patients, it's really difficult. We understand that cancer care is difficult. And then sometimes, you know, after telemedicine visits, we have to bring them in. Really, that's kind of a risk and benefit assessment for every doctor, between every doctor and patient to make that decision.
Yeah, thank you so much, Dr. Sawa. Again, another question is about the plan to have health workers in the infusion center get tested on a rolling basis, because when you get tested, it's not like an education certificate that you are going to remain negative forever. You can even be negative today and tomorrow you're positive for COVID. So this is a great question. What is your plan, since you are in charge of that in a cancer center?
Yeah, this is a frustrating part. You know, a month ago, I was so frustrated. I was because one of our nurse managers who had COVID-like symptoms couldn't get a test, and that was very frustrating for me. And because we were gearing the resources toward the sickest patients, the ICUs, the hospitalized patients, and right now we have the capability of doing PCR testing because we have an internal test and antibody testing. You know, the question of testing our healthcare workers started more than a month ago. But I think, you know, right now we have the capability of testing anybody that we want. So that's a good thing. You know, the really next step is, should we routinely test our healthcare workers to make sure that they're safe and healthy? In terms of antibody testing, there is currently an initiative to do an antibody test for all healthcare workers. And I think that may be important, but you know, I think the reality is we think those with antibodies that could be protective of reinfection, but you know, certainly at this time we don't have definitive data to support that. You know, there's the theories about various strains of the virus. There's theories about, you know, how much immunity is enough. There's certainly cases coming out of Korea, or reports coming out of Korea, where positive patients who tested negative then tested positive again afterwards. And whether that is due to because of imperfect testing or because somebody's reinfected, I think that's something that we have to, you know, understand with more evolving data in the future. So currently, I guess the question is there a role in routinely testing healthcare workers who are asymptomatic? Well, you know, we take the precautions. We ask our healthcare workers to take the necessary precautions at work, which is to socially distance with each other. All of us are masked, practice hand hygiene. We have morning rounds to make sure our staff are asymptomatic. We gather our staff and to make sure that they're okay. I think, you know, currently, because of lack of data of supporting who's really 100% safe or not, there's no plans or role currently as we speak to test healthcare workers periodically. You know, if we could get, let's say, the Abbott test, which is a 5-minute test, should we be doing that if we had that capability? I think that's an interesting question. That, you know, the concern about the Abbott test, the 5-minute test, is that there's a lot of false negatives. So, you know, what if you test and somebody's, you know, falsely negative, but now you're exposing them to others as well? So I think in this environment and with our current capability, I don't think there's a role currently as we speak to routinely test our healthcare workers. But certainly, I think it's important to understand. And I just, show you a quote from or a slide from Andrew Cuomo on Monday, where they show 24.7% of a random sampling of antibodies were positive in New York City. I mean, that's a striking number. And I'll tell you some of our internal data shows very similar numbers. So I think this is really an evolving subject that we have to kind of look at periodically, but currently no.
Yeah, thank you so much, Kai. I agree. It is really a very challenging disease because the fact that it looks like people infect others even before the onset of symptoms, that means the latent period is higher than the incubation period. It is really quite very challenging because the symptomatic assessment of health workers and others, as much as it will help treat the patient, but may not help to stop, the spreading of the disease, because people might have infected others some days before they see any symptoms. So it's still, the issue is social distancing that will help, but for how long are we going to really do this? But thank you so much, and this is going to be a continuous discussion throughout, and we hope to really discuss more as we get new evidence. Francois from Rwanda Biomedical Center says comment on the issue of preventing cancer, because this is quite challenging. He says that self-sampling would be great, but the visibility of it, especially things to do with sample processing and transportation and then giving feedback and so on. So it's quite challenging, but I think with the proper planning and all of deciding that this is a better option and the way to go, I think it is possible. In Uganda, we for example, we have a very good transport system, actually one of the best transport systems for the TB samples, the Ebola samples, the measles, and it really works very well. And since that system came in place, in Uganda, outbreaks like Ebola, we just recognize 1 or 2 cases and they are controlled. The system works very well in terms of delivering the samples and also delivering back the results. And we have also started it with a cancer diagnosis. It really works very well with the central lab. And with the current technology of sending WhatsApp and results, the sending physicians and so on, I think with well planning, self-testing and making sure that the transport hubs of the samples and specimens and specimens extend beyond diseases, because now they work very well for TB, they work very well for measles, they work very well for Ebola and so many others. So we only need to leverage on those, and then we add on samples for cancers, because it doesn't make sense for a hub coordinator to pick samples for TB in a hospital or in a community and leave the ones for cancer. So, sorry, in the interest of time, we may need to stop the discussion here, and members are welcome to continue this discussion on the base camp. Actually, very interesting, and we should, I think, start a link about this and see how we can go forward. So to sum it up, from Dr. Sao, as he said, he has given us a way forward of testing, providing PPE, of making sure telemedicine is implemented and reduce the exposure of cancer patients, and of course, social distancing and infection control measures are very important when it comes to the hospital. Thank you all. It was very interesting to see what you really experienced and the way forward of suggesting the self-sampling so that we continue having the tests done. With the vaccination, it is still a challenge of having girls come, but Brenda had very good suggestions. So now I would like to invite Mishka and Christine to make some announcements on the way forward.
Thank you everyone for joining. It was lovely having all of you. Thanks so much to our presenters. We have learned a lot today. So over to Mishka to announce about the next session. Thank you.
Yes, thank you again, everybody. This has been fantastic. In the month of May, hopefully you all have received notice that we will be holding a series of weekly sessions as opposed to our usual monthly, targeting different aspects of cancer care considerations in COVID-19. Actually, next week's session will have the case presentation by Dr. Francois, who joined us here today, as well as a didactic from Professor Chite from the International Cancer Institute. We are inviting anyone to volunteer to be case presenters throughout the month. As Kai said, this is ever evolving very rapidly, so your presentations are absolutely key to making these discussions effective. So look for more email information. If you're not receiving them, email me at mishka.sira@nih.gov. And thank you again, everybody.
Yeah. So thank you, Mishka. It looks like we have come to the end of the session. I would like to thank Aurora and Kai for the great sessions and for sharing their great experience with us. And thank you all for attending. I look forward to seeing you next week. Thank you.
Thank you.
Bye, everybody.
Bye.